Hi, all. Welcome back. We're going to continue talking about the respiratory system. We're going to spend kind of the next little bit of time on the lower tract of the respiratory system. Okay? And so remember, after the larynx, you have the trachea, and so you have what sometimes is called the windpipe. And the trachea is this tube that runs from the larynx down into the lungs, and it's probably its best feature, the easiest feature for students to learn, whether it's the trachea or the esophagus. You have two tubes that are running from um, your like nasal cavity, buccal cavity, that kind of region of your body down um, through the trunk of the body. You have two tubes, an esophagus, which runs from the mouth to the stomach, and then a trachea, which is running to the lungs. Now, this trachea is going to split into what we call the primary bronchi. Okay, so you have a left and a right primary bronchi, which feed the left lung and the right lung. Okay, and they'll split even further from that when we talk about the lungs anatomy. We'll get to that. But along the entire bronchi and even the trachea, you have those same features that we saw in the nasal cavity, same features that we saw in like the nasal pharynx and things like that. You have these pseudo stratified ciliated pulmonary epithelium cells with goblet cells. Okay. And so, as you can imagine, these regions of the body have little teeny finger like hairs associated with mucus producing cells. And so, the whole passageway, even through um, the larynx into the trachea, into the primary bronchi, you have these passageways that are lined with little hairs and mucus producing cells to capture any foreign material that has made it into that region. As you break down from the primary bronchi into secondary or smaller bronchi into the bronchus, and then into the alveoli, you get less and less of these ciliated cells, because once the material gets that far down, there's really nothing that's going to lodge that material out. And we'll talk about this in a little bit. But the feature that normally students are really associating with the trachea is the hyaline cartilage, or the rings, the tracheal cartilage. And so these rings, although they look like a complete ring, it's really just a C shape. Okay, the back portion of the ring is open. Um, but that prevents the trachea from closing on itself. Okay? And this is really important from the perspective of your windpipe doesn't collapse, okay, unless the cartilage is broken. But those cartilaginous rings keep it open at all times. A tracheotomy is when you might have some food, or maybe you have an allergy that has swollen the upper portion of the trachea, and it doesn't allow the air to get through. Okay? Sometimes anaphylactic shock, sometimes a piece of food might get stuck um, in the epiglottis region and might get stuck there, and it can't get dislodged. And then, and I'll show you a little picture of this. Then the procedure is to actually cut a hole in the trachea to allow for the air to then travel past that blockage. And this is often seen on movies and shows like that, but it is done. If someone really has a blockage, it's often done from that perspective. So here you can kind of see just that lower region of the respiratory system. You have that larynx, which we already talked about, thyroid, cartilage, etc. And then you have this trachea. Okay, so everything that's after the larynx is related to the trachea, at least from the cartilaginous rings. Okay. Feeding the primary bronchi, left and right. Okay. Those cartilaginous rings kind of give rise to cartilaginous plates. So they stop being a ring and start being elongated plates. But again, same kind of purpose. So the material has some rigidity and doesn't collapse on itself. And then you can kind of get into these smaller bronchi, smaller branches, which has less epithelial cells that are ciliated, less rigidity to them, more flexible. And normally these regions are controlled a little bit more by muscle, like smooth muscle, which allows you to contract and relax those regions so more and less air could get in. Okay. So here you can just see kind of part of that smooth muscle being associated with the cartilaginous ring. Hey, you can see, if you look close, you can see the ciliated cells with the goblet cells next to it. Again, so the trachea is lined with cartilaginous C-shaped kind of ring, provides the rigidity, some smooth muscle which can contract this a little bit, right? And then these epithelial cells, which provide some mucus and the clearing capability of material that might be caught. This is a tracheotomy. Okay, so underneath the thyroid gland, okay, a little slit is made. So just above the jugular notch, a little slit is made. Okay, normally because that blockage or food bolus, or even the tightening of the muscles, the inflammation that might occur, it might close off the glottis, or the blockage might be a little bit higher near the epiglottis, and you want to bypass the larynx and get straight to the trachea so you can still get oxygen into the lungs. Okay. All right, let's look a little bit at the bronchial tree. So again, you can think of it as one large tube. Okay, that's the trachea, splitting it's branching into a left and a right side. Okay, and then those branches branch further and even further, okay, until you get into microscopic air sacs. So the right and the left are called primary bronchi, and of course they're feeding the right and left lung. Okay, the lobar or the secondary bronchi are branched off of the primary. Okay, there's 2 on the left, 3 on the right. Okay, this should make sense to you because the left has 2 lobes, the right has 3 lobes. Okay, and then you have tertiary bronchi or sedimental bronchi, and you have even smaller units than that, 8 on the left, 10 on the right. Okay, interlobular bronchialis. Okay, so each enters a lobule. Okay, lobule is a section of the lung. Okay, and even further from that, you have 40 to 80 different bronchioles. Okay, little teeny small branches. Okay, within each lobule. Okay, and so again, it's just tracts. So you have large pipes, small pipes, even smaller pipes, etc., etc., etc. Some are flexible, some are controlled by muscle, some have ciliated cells that help clear things, some don't, some are associated with alveoli, where you're going to have some gas exchange. So those alveolar ducts, okay, are the regions at which the respiratory bronchioles are going to terminate. Okay? And then you have some sacs that are associated with that. And then the alveoli itself is the individual air sac, okay, that has a single epithelial, most of the time has a single layer of epithelial cells, which will allow for oxygen and carbon dioxide to transfer across the material. Okay, so let's look at this. So again, trachea into primaries, into secondaries, into tertiaries, okay, and then each lobule or each region of the lung, whether that be the lower, middle, upper, okay, it's going to have multiple lobules or multiple sections, okay, and what you would see is something like this. You have these bronchial trees, okay, that kind of terminate with alveolar buds or alveolar sacs, and then the alveoli is the individual sac-like structure where gas exchange occurs. Okay? Associated with this is often those arteries and veins. Okay, so remember the pulmonary artery coming from the heart is going to be sending oxygen, poor blood to the lungs, and then the pulmonary vein coming from the lungs is going to send the oxygen rich blood back to the heart. Okay, and so you have these pulmonary arteries coming in, capillary bed where the two are connected, the vein and the arterial are connected. That's where the passing of the oxygenated blood or passage of the oxygen into the blood occurs, and the carbon dioxide occurs also, and then the pulmonary vein will return oxygen rich blood with low carbon dioxide levels. Here you can see a cast of the bronchial tree. Hi, again, you can see that it's lots of branches, lots of regions for transfer of gases. Okay, the more surface area you have, the higher the capability of transferring gases between a liquid, or in this case, cellular components and the atmosphere. Okay, if we're diving into what an alveoli looks like, okay, you can see these small sac-like structures with really thin cell layers surrounding them, okay, and then associated with capillaries that are associated with those, so the blood can transfer carbon dioxide and pick up oxygen. Okay. The bronchioles, again, this is just kind of an electron microscope graph or picture of what's going on. You can see these alveoli sacs or alveolus, okay, very thin membrane, okay, the bronchioli, much thicker, okay, carrying the air to these passages for the transfer. And we'll get to how that transfer works. Okay, that transfer is based mainly on pressure, the outside pressure or the partial pressure of the atmosphere versus the internal pressure of the organism's body. In this case, we'll mainly talk about humans. Okay, but that difference, called Boyle's law, is what kind of drives the normal functionality of lungs. But we'll get into that in a little while. Okay, so the structure again, though, just to recap, you have the main bronchi, which is very similar to the tracheae. Okay, so these are the primary bronchi, the left and the right. Okay, very similar to the trachea, except for, like I said before, they have cartilaginous plates, not the cartilaginous or the C-shaped rings. And as you travel, it becomes more narrow and the cartilage decreases. As the cartilage decreases, you start to have more smooth muscle be present. Okay, so if you have all these cartilage plates, it's hard for the smooth muscle to contract. Okay, so when the cartilage plate is gone and the smooth muscle is there, then you can contract, release, or relax, so you can do what we call bronchial dilation or bronchial constriction. And that's just a way at which you can control how much air is traveling through the bronchioles into the alveoli sacs. As you travel further down, though, the smooth muscle tends to diminish and get to be less, along with what we talked about before. The ciliated epithelial cells tend to diminish as you travel closer and closer to the alveoli, to the point where you get into a simple squamosa epithelium, or one cell layer thick epithelium, and that allows for that gas to exchange readily across from the alveoli sac, from the atmosphere gas, into a dissolved gas, which is going to dissolve and be carried by red blood cells, or dissolved into the plasma and out of the plasma. Okay, so again, most of this is pretty much review. The purpose is really to transport air, okay? Especially the upper portions of the bronchial tree. There's no gas exchange that's occurring. The cells are too thick. Those cartilaginous plates don't allow for any air to transfer, so the air has to make it all the way back down into the alveoli sacs to get at that. Okay, so alveoli is where we have gas exchange. There's lots of surface area. You saw the terminal branches of the bronchi. There's lots of them. Attached to that are all these alveoli sacs that would provide lots of surface area for gas exchange. And just to recap, oxygen is transferring from the alveoli across the membrane, okay, through the capillary wall and into the blood. Okay, we talked about this before. Oxygen is carried by hemoglobin. Okay, it's carried by the iron molecules in the hemoglobin, and that's kind of how oxygen is transferred. Carbon dioxide is a little bit different. Okay, so carbon dioxide can be transferred in a couple ways. It could be transferred via its bond to water to form carbonic acid. It can be transferred as carbon dioxide binds to hemoglobin, and so you can get carbon dioxide binding to hemoglobin, and then it can be transferred just as a gas in the plasma in small amounts. Okay, so there are a few ways at which carbon dioxide can be transferred, and it still occurs in the same way, except for it's a little more complex when it comes to carbon dioxide, because it can be transferred in multiple forms. Some of these forms are easier to just pass across the alveoli sacs or across the alveoli wall. Some are a little more difficult. Some has to be transformed into a different molecule to pass out. And we'll come back and talk about that in a little bit. Okay, so here you can just see that pulmonary artery or arteriole. Okay, again, remember, arteries give rise to arterioles or smaller arteries. And so this is a pulmonary. It's coming from the heart. Okay, runs along the alveoli sac. Okay, and all along here, when there's oxygen, high concentration of oxygen inside the sac or inside the alveoli tissue, and there's low concentration inside the blood, okay, diffusion will occur. Oxygen moves from high concentrations to low concentrations. So along this channel, the oxygen will continuously move in until it becomes saturated, or until the two become somewhat equal, and then the blood, there will be really no more net gain transfer. There might be transfer still occurring back and forth, but there's no net gain in either system. Okay? Same thing with carbon dioxide. The carbon dioxide is high in the blood. It's low in the alveoli sacs. Okay, so the carbon dioxide will tend to go from high to low until the two areas are basically equal. Okay, you can see there's lots of space, lots of surface area. blood vessels, capillaries associated with these regions, these alveoli sacs. So there's lots of area for transfer of oxygen and carbon dioxide to occur. The lungs themselves, you find that they're just soft tissue, kind of a spongy tissue that is associated with these alveoli sacs. Again, we talked about this before. The right lung has 3 lobes, the left lung has 2, although there are cases of individuals with a 3rd lobe in their left lung, but for the most part, the right lung is a little bit larger than the left lung. Okay, the left lung tends to be a little bit longer. And then the right lung is a little wider and truncated, but 3 lobes, because the right lung's dealing with the liver underneath it, the left lung's dealing with the heart associated with it. So both are kind of truncated by these organs, and their shape has evolved to be associated with whatever the organ is associated with them. The metastatum is just a protective kind of layer of connective tissue that separates the heart from the lungs to protect the heart and the lungs from one another. The pleural is really this membrane that surrounds the lung, and so often we'll see that individuals will have maybe fluid that occurs in the pleural cavity. Okay, sometimes when they have infections like maybe pneumonia or something like that, sometimes fluid will build up in these cavities that will provide less flexibility in the lung. Very similar to what we were talking about in the heart, when you can get some fluid buildup in different regions around the heart, causing the heart to be less flexible. Also, same thing can happen in the pleura. The pleura itself is really it's the importance of it is protection for the soft spongy tissue of the lungs, just like we saw with the pericardium in the heart. Okay, and so very similar role between the two. All right, let's finish off talking a little bit about lung irritants. Okay, the lung irritants that, of course, there's lots of them. We're not going to spend time on all of them, but there's some that are well known and probably associated with quite a few diseases, disorders that are common enough that if you're going into allied health or nursing or as a physician or whatnot, you'll probably see these lung irritants fairly often. Asbestos, hopefully this is becoming less and less prevalent, but as buildings age, and we used to use a material called asbestos, it was a fire retardant material, so things like roof tiles, just different types of material that was used in construction used to have these fibers that ran through them. But those fibers, when they are broken, they're very, very small, okay? And they can get past the cilia. And so they would get into the pleura, they'd start damaging the cells. And anytime you have damage to cells, we talked about this before, those damaged cells will often regenerate. Okay, they'll be damaged, they'll be destroyed, okay, and then new cells will regenerate. And if this happens quite often, you could develop a cancerous tumor in those regions. And so that's what we've seen with asbestos. It tends to lead to lung cancer or extreme scarring in the lungs, if not, a mesothelioma or a cancerous tumor in the pleura. So berylosis or beryllium is an element that's often used in industrial applications, and it's it's very similar or dangerous as asbestos in this sense that it creates scars. And anything that's going to create scars in the lungs is dangerous from the perspective of you'll have dead space. Okay, so that scarring will prevent the transfer of oxygen in certain regions from the alveoli sacs. So those alveoli sacs will get thicker and thicker. And so now instead of being a single epithelial cell thick, it might be multi epithelial cells thick, or you might have scar tissue, so this connective tissue that builds and it doesn't allow for the transfer of gases. So then you have these pockets inside the lung that there's no transfer that can occur. The oxygen and carbon dioxide might be able to get there, okay? But you have very limited transfer that occurs in that region, okay? And that really impairs individuals' capability of breathing, and they get these dead pockets or dead space. Allergies or allergic elephantiasis. Okay, this can be related to lots of different things. Exposure to organic material. We see a lot of this in individuals that might be associated with farming practices or maybe processing food. So if you're processing lots of wheat or corn or things like that, and you're constantly shucking or constantly removing kernels and things like that, or you're in a facility that does this by machine and there's a lot of dust of this organic material that's flying up in the air, it can cause chronic changes in the lungs over time. And so it does damage from the perspective of the immune system often will relate or be forming an immune response to this organic material that's accumulating in the regions of the respiratory surfaces. And then, of course, air pollution is another big one. And this really just, it depends on what type of air pollution. It depends on what's causing the pollution. If it's industrial factories, if it's motorized vehicles, if it's airports, it really depends on the pollution, but it can all have an adverse effect on the alveoli. It can damage the cells. It can impair the passageways. It can cause inflammation to occur, very similar to asthma. May even result in asthma. It could make the asthma worse in individuals that might have asthma, but it just worsens the effects by causing even more inflammation. It can irritate other surfaces, of course, the eyes and things like that. And what we see is a much higher rate of asthma in individuals in urban environments than we see asthma in individuals in rural environments. And most likely this is the result of higher levels of air pollution. Okay, next time out, we'll talk about how the lungs actually work, like what causes air to travel into the lungs and out of the lungs without you thinking about it. So an automated process.